All right, good morning, everyone. Today I'm gonna do an intro to health policy, just some background. I did this last year, just some background on why I'm doing this. Thank you to Ronnie and Dr. Willis and the people speaking before and after me for sharing some of the conference time today. So every year, ACEP has a leadership and advocacy conference, which is like a big Hill Day in Washington, D.C. And as part of that EMRA and the ACEP Young Physician section, we put on a health policy primer. Obviously, a lot of that's been modified because of COVID. We've moved all of it virtual. So for the primer, what we're doing is some pre-recorded lectures, and then we're going to have live sessions on April 26th, which I'll send the information out to you guys later. I hope you guys can come join that. So this is just the lecture that kind of kicks off the health policy primer track. Sorry if you heard this last year, but hopefully you'll still get something out of it. So this session is being recorded for that live conference. I just wanted to do it in conference to have a live audience instead of talking to a computer. So thank you for being my audience. So with that, all of the online people are muted, and please don't make any abnormal noises for the recording. Okay, good morning. My name is Angela Kai. I'm the EMRA Director of Health Policy and a second year at SUNY Downstate Kings County. Today we're going to talk about an overview of the U.S. healthcare system, introduction to health policy. Our agenda today is going to be what does our system look like now? How did we get there? And then what's next? So in the middle of our system is the doctor-patient relationship. Everything revolves around that. Unlike normal services out in the world, like if you go to the restaurant, you have dinner, you pay for the meal, most patients don't pay directly for their service at the time that they receive the service in the healthcare system. Where is that money coming from? We have different insurers paying for our healthcare. About 20 of that comes from private businesses. So this is generally employer sponsoring employee healthcare. Another chunk of it comes from households. So that's you and me as individuals paying out of pockets, paying our premium. And then about 45% of it comes from public sources. So that's local, state, and federal governments. And a smaller percent of that, about 7%, comes from other sources like philanthropy. So all of this is our system, and it happens in a background of government regulation. And what does that look like? Most of that lives under the health and under the health secretary, Secretary Azar, and these are some of the big agencies that regulate our healthcare system. Under the public health arm, we have the CDC. The National Institutes of Health is our federal funder of biomedical research. We have the FDA, which regulates our vaccines, CTs, x-rays, and medications. And finally, a big player is CMS, which is the Center for Medicaid and Medicare Services, probably one of the single most influential players in our delivery and payment system. And let's talk a little bit about why CMS is so influential. So if you go back to this slide as to where the healthcare dollars are coming from, you can see that on the right side, where it was public funding, CMS commands a huge amount of those public dollars. And CMS is the single payer in our healthcare system. They tend to set the standard for what payment rates are and what kinds of quality measures we're going to look at. Another way that CMS is really influential is through EMTALA, which is really important for us as emergency physicians. EMTALA is the Emergency Medical Treatment and Labor Act. It says three basic things. First, every patient that comes to the ER gets a medical screening exam to determine if there is an emergency condition. And if there is one, then they must be stabilized and transferred to a higher level of care if necessary, and the accepting facility must accept that transfer. The interesting thing about this is that all of this is regulated through Medicare and Medicaid. So while not every single patient in the hospital is a Medicare patient, Medicare exerts such a great influence that hospitals apply this to all of their patients. Of course, treating everyone that comes into our door is part of our job as emergency physicians and part of our moral code, but this is how it's codified in the law. If you have an EMTALA violation as a hospital, the way you're penalized is that you can get a financial penalty, or you could risk losing all of your Medicare reimbursement. So Medicare reimbursement is so important that even though not all patients are Medicare patients, all patients are regulated under EMTALA. So this comes to our first of 4 themes in our healthcare system, which is that the government holds the purse and the power. The second theme of our system, we're going to talk about 4 big themes, is that our system is really high cost, and this should come as no surprise to all of you. Some numbers to measure that: we spend $3.6 trillion nationally. 1.1 trillion of that comes from the federal government, and that doesn't include about $280 billion, which is not money that's collected, but the money that the government forgoes collecting through tax exemptions, primarily through employer-sponsored insurance. And all of this equates to about 1/5 of our economic activity, as measured by the GDP. So what exactly are we paying for? About 1/3 of that is going to hospitals, 20% to physicians, 10% to drugs, and the rest of it goes in smaller slices of the pie to things like home health care, nursing home care, medical equipment, and dental. So when we talk about where to reduce costs, certainly physicians and drugs are a big part of it, but we also have to remember that respectively they're 20% and 10% of the total healthcare cost. Where does the United States stand? If you look at us compared to other developed economies in the OECD, on the x-axis we have plotted GDP per capita, so that's a rough measure of how big an economy is, how much their economy, how the size of their economy per person. And then on the y-axis you see how much we're spending per person. There's an obvious trend line that makes sense, which is that the bigger the size of your economy, the more you'd spend per person. But you can see the United States is way outside of that trend line. We are spending a lot more per person than you would expect for the size of our economy. And what exactly are we getting in return for that? So if we look at some basic measures of quality, just some really big picture measures of quality of a healthcare system, you can see on the left is our spending compared to the other OECD countries. And on measures of life expectancy, infant mortality, maternal mortality, and premature death, we are ranking far below the other countries. So this comes to our third theme for the system. We are a high-cost system, but on average, we're delivering really low quality for an average American. Another way to reframe this is in terms of value, where value is how much quality are you getting for how much you're spending. So on average, the US healthcare system is a low value system. So this is all really overwhelming. You know, really we just went to medical school to be doctors, to take care of patients, but there's this huge background and there's a lot of money that's happening behind us. And it's really important that we know about this so we know how to advocate for our patients. So how did we get here? The important thing to remember about how we got here is that it's just a history of a patchwork of fixes to our system. It wasn't a system that was designed. So we can talk about the healthcare system in terms of how our patients are covered, their insurance coverage. This obviously doesn't capture everything about the system, but in this country, coverage is a crucial component to how you access the healthcare system. So it's a nice illustration of our history. So the way that our patients have been covered throughout history is kind of a story of the political climate of the times and legislative fixes that were politically palatable at that time, influenced by special interests. So if you divide the US population, which is about 330 million people, into different segments, you'll see that this corresponds to how they get their insurance. So most people are employed and get their insurance through their employer. There are some people that buy it themselves. Those are individuals. And on the top half of this patchwork is private insurance, and on the bottom half is public insurance. So you have veterans that get coverage through the VA, you have the elderly, poor, and children, and then there are other populations that kind of got worked into the public system, like those who are disabled or are end-stage renal disease patients. So each of these populations corresponds to a different source of insurance. So we talked about the employer-sponsored insurance. The reason this is such a big segment of our population is that during World War II, employers started offering health benefits as an alternative to salaries to attract attract employers. And the federal government picked up on this and started providing tax exemptions. So that is responsible for the huge growth of employer-sponsored insurance. The important thing about that is that it creates job lock for a lot of people. If you're part-time, maybe you can't get employer-sponsored insurance because your company is not big enough. Or if you're in between jobs, you might also lose your health insurance. So there's a lot of advantages to employer-sponsored insurance. Obviously, a lot of Americans are happy with their employer-sponsored plans, but there are some downsides to being so dependent on that system. And then on the bottom left, we have the VA for veterans, like we talked about. Veterans have had some form of health insurance since the Civil War. And then all these other populations were covered over time as healthcare became more expensive, and we were recognizing that there were vulnerable populations that weren't being covered. So in the 1920s and 30s, the US government started studying the cost of health insurance, but it was nothing like it is today. It wasn't a huge burden on the population. And if you go back to the 40s during and Depression era times, most people were more concerned about their economic and employment security. Healthcare was not a big thing. So that's why we get Social Security, and then we get healthcare coverage. But finally, in 1965, you have Medicare and Medicaid that are passed. At the time when it was passed, Medicaid was never thought that it was going to be such a huge program that it is today. And today, Medicare is about $600 billion. Medicaid is about $400 billion. Medicare covers those over 65 in 4 different parts. Each part pays for hospitals, physicians, drugs, and then there's also a private-public partnership supplement, which is called Medicare Advantage. And then Medicaid covers people typically under 200 or 300% of the federal poverty level. And then over time, people recognize that there's still people that we're leaving out of our healthcare system. So in 1972, there were some amendments to the Social Security Act passed, and disability insurance was added to CMS. And interestingly, so was dialysis. So this is the only disease that's specifically covered. And interestingly, one of the stories that came out of that is during the hearings on committee hearings during Ways and Means, there was a dialysis patient who was 40 years old, and he gave a really compelling testimony on how much being on dialysis affects his life and how much he depends on this and how it affects his job. And then during the hearing, he was also dialyzed for a period of time. And so this is kind of an illustration of things that get put into our healthcare system are just kind of based on the advocacy that's happening at that time and what the political momentum is at the time. And finally, of course, everybody cares about children. So we recognize that children were not being covered. So that's how you get CHIP, the Children's Health Insurance Program, which is a joint partnership with Medicaid. An important thing to know about Medicaid is that it is a state-federal partnership. So Medicaid is not just one program, it's actually 50 different programs. So finally, in the top right corner, you have what was the individuals, and they can purchase insurance on the ACA exchanges. And then you have 31 million people, so that's almost 1 in 10 people in our country that still remain uninsured. And when the ACA came along, if you think about this patchwork of who's not being covered, the ACA was mainly a coverage bill, and it was trying to cover the gaps that were still left in our system. Most children are covered, most elderly are covered, but there's still people who are employed that are not covered. So the ACA in its full form as it was designed was trying to fix this by expanding already existing components of our system. For example, through an employer mandate, telling employers to cover their employees, through an individual mandate, obligating individuals to purchase insurance and creating exchange places where people can buy that insurance, and also through expansion of Medicaid. But obviously, we've seen a lot of those components being chipped away, and so that's why we still have this huge coverage gap. So all of that was really wonky. If you want a way cooler version of this history, check out Cleavon MD, and he has a great rap on the history of health insurance, commissioned by EMRA. So what's next? Next is MACRA. This is a huge, complicated law, but it's really going to define the future of how we get paid. MACRA is the Medicare Access and CHIP Reauthorization Act. The CHIP reauthorization part is just continuing to fund the CHIP program. And then The Medicare part is it's redefining how physicians get paid through Medicare. But remember, Medicare is really influential. So if Medicare decides to reimburse us differently, the rest of the system will follow. There are two main tracks to how you can get paid. One is MIPS, the Merit-Based Incentive Payment System, and the second is a little more complicated. It's called Alternative Payment Models. You could take a whole course on this, so we're just gonna talk really broad strokes. So the idea behind MIPS, behind this whole program, this is known as the Quality Payment Program, is that instead of just getting paid for doing a certain number of services, you also have to be accountable for the quality of healthcare that you're delivering, how much it costs, whether or not you're trying to improve your practice and use the electronic healthcare record intelligently. And so CMS is going to track all of these things and give you a quality score, and that's going to lead to payment reductions or bonuses up to 9% over the next several years. Alternative payment models are a little more complicated. These are things like bundled payments or accountable care organizations. They're a little less accessible to emergency physicians in particular, but the advantage of doing these is that you can access a 5% bonus in payment. So all of these programs are already here. Obviously, they're a little bit delayed because of COVID, but these are things that we have to look to in the future. So going forward, just some resources to know about. ACEP has created programs to help practices and emergency physicians get paid in this new era. One is CEDAR, the Clinical Emergency Data Registry, Emergency Quality Network, EQUAL. These are programs to help you track your quality metrics and report them to CMS. And on the APM side, ACEP actually developed an APM model. It's called the Acute Unscheduled Care Model, which you can call awesome. And you can visit that website to learn more information. So where are we going? All of these things are what we call a shift from volume to value. Instead of being paid a fee for a particular service, you have to get reimbursed based on the value of care that you're delivering, your mortality outcomes, and how efficient you're being with your resources. But the reality is that our system has been there before. There is a whole alphabet soup of things that we've tried in the past, and as we're looking forward, it's really important to know where we've been. So ultimately, this leads us to our fourth lesson, which is that there is no panacea. Our healthcare system is really complex. It was a patchwork that was built over decades. There's not going to be a single policy, a single reimbursement reform that's going to change everything. So here's an overview of the 4 lessons we've talked about. The government, although we don't have a nationalized healthcare system, exerts a tremendous amount of influence on how our healthcare system is designed and delivered. We, on average, deliver a high-cost, low-quality healthcare compared to the rest of the world. Our current system exists the way it does because it was a patchwork of fixes over time, and there's not going to be a single solution that's going to fix it. So what's next from an advocacy standpoint? What are we going to do about it? It's important to recognize that policy and advocacy happens at all levels. So while it's easy to think about things like the Affordable Care Act as shaping our system, there's actually a tremendous amount of things that happen at different levels that influence the way that we practice. So here are some big picture examples of things that really influence our lives as emergency physicians and the way we take care of patients that are not just national legislation. Things happen at all levels, whether it's local, state, or national, and they happen in 3 broad buckets, whether it's legislative, regulatory, or professional. Legislative is pretty straightforward, that's passing laws. Regulatory is all the things that government agencies tell us to do that have a huge influence on how we practice. Just think about CMS sepsis metrics. That's not a law, that's something that CMS regulates. And on the professional level, these are organizations that we as physicians create to help regulate ourselves, like medical boards. To kind of illustrate this, let's talk about policy and advocacy as it's happened just in the last month on the COVID-19 pandemic. On the national level, we have the invocation of the Defense Production Act to try to help speed up the supply chain for PPE. At the state level, many states have passed legislation, such as New Jersey, which passed enacted legislation saying any lab can collect COVID-19 testing. On the regulatory level, there's been huge changes over a really short period of time. For example, there have been many EMTALA waivers that give us more flexibility into how we screen patients, and this was a huge win for ACEP regulatory advocacy. There have been relaxed nurse practitioner and physician assistant supervision. This is generally regulated at the state level, and because of the pandemic emergency, a lot of those supervision requirements have been relaxed, and this is something that will be interesting to see whether it sets a precedent moving forward. At the local level, you have cities closing parks. At the professional level, ABEM, which is American Board of Emergency Medicine, has forgiven quarantine time. Normally there are restrictions on how much time you can have off as a resident to qualify for board certification. But thanks to EMRA's relationship with ABEM and responding to all of residents' voices, ABEM released a letter saying that quarantine time would be forgiven and not count against your qualification for graduation. Also at the state level, we have expedited licenses for retired docs to bring them back to the workforce. And at the local hospital level, we have our own hospital disaster plans. So since you're listening to this lecture, you probably think that advocacy is important, but I want to frame why it's important and leave you with one final thought. So literally, there has never been a time when our healthcare costs more, and there are going to be more people looking at the way that we practice, what kind of data we collect is important, and how we're going to get paid. And the reality is, if we're not at the table, then we're at the menu. So here are things you can do today moving forward. You can make a donation to NEMPAC, the National Emergency Medicine PAC. This is our largest political action committee. In order to have a unified voice on the Hill, we have to speak with money and a unified voice, and this is your way to do it. Join the ACEP 911 network, which provides weekly updates and will tell you any urgent needs to contact your congressperson for. Keep learning, and a great place to start is the EMRA Advocacy Handbook, which is free and online. And make sure to use your advocacy platforms, whether you're a resident or an attending, those for you can be ACEP and EMRA. Whatever it is, make sure you find your avenue and stay involved. All right, thank you.